I'm pleased to be here and pleased to have the opportunity to have these lectures that I'm giving. So it is a series of 5 lectures, 5 2-hour lectures. And the theme for the first one is to give some information of the background of the psychiatric system in Finland, the background of this specific way of working that we are dealing here in this lecture, calling need-adapted approach, and then specifically focusing on open dialogues and how it was. And in that respect, I will tell something of the entire Finland, but more and more in the end of the lecture focus on what happened in the small province of Western Lapland. And meanwhile, I will also put in front some critical questions of concerning our understanding of psychotic problems, because we actually now have a very fresh outcomes to show that these problems perhaps should be seen in a very different way that we are used to think of psychotic problems. The second lecture that I'm going to give tomorrow deals with the main principles of the idea of open dialogue treatment as it was constructed in Finnish Western Lapland. The third subject of the lecture will focus on the open meeting, generating dialogue in the open meetings. What are the basic qualities? Why is it focused on, and how do we increase our skills in this practice? The idea of the fourth lecture is to focus on the present moment, the intersubjectivity, and those kind of aspects to give us more understanding what is the power, why dialogical meeting can be such a powerful occasion. And then the last meeting is focusing on these research issues from a naturalistic point of view, as I'm saying. What is the place of doing research of our own practices? What is the place of doing evaluation of our own practices? And I will give examples of the research that I have been involved, mostly focused on things that has happened in Western Lapland, but also some other studies. Those studies are mainly on psychosis, but also, at least the latest one, focusing on severe depression, and that's I will have as an example. But today, our aim is to start off the question of the background to understand how is the context in the Finnish system. First of all, I have here a map to show. What is Finland? I'm sorry to this map, because the United States and Finland are so far away that I couldn't manage to have states here in the same map. But this is the northern part of Finland. This is the Arctic Circle line going here, so it's actually quite north on the whole of the globe. And I'm working and living here in the city of Jyväskylä, in the University of Jyväskylä. I'm having a position as a professor in psychotherapy now, so my focus is very much on psychotherapy research, psychotherapy education for the last 12 or 13 years. So my context at the moment is a university perspective of developing the practices. But of course, the main part of why I'm here speaking of this is related with this small province here around in Tornio. Actually, it's limited to the Arctic Circle, as is northern part. This is the area of the province, small province in the northern part of Finland. These other signs of the map describe a kind of unit that has been involved in our northern network of treatment of psychosis that we meet every year. So never mind of those parts of the yeah. Okay, we can perhaps come back to this map if need. But then saying something background of this Finnish context of treatment, and that's because the Finnish context of treatment is very different compared to how the system is organized in the United States and perhaps mostly in the most part of the country. And the Finnish system is very much related with as we call it, as a kind of a Nordic social and healthcare system, welfare state idea. And the idea is on the whole to introduce health and social services by tax money for the entire population. And this still is the case in the Nordic countries. Nordic countries, actually, I have to say this. So that there are two concepts that are used usually of this part of Finland. Someone called these as Scandinavian countries, but being precise, actually, Scandinavia is only these three countries: Norway, Sweden, and Denmark. So Finland is not a part of Scandinavia, but more accurate from our point of view is to call those as Nordic countries. And of course, we include in Nordic countries also Iceland, situated here. And all in these countries there is this Nordic welfare state idea that everything is based on the tax money, and every services are free for all population. Which means in this respect the thing that decisions concerning social care, decisions concerning healthcare are made by clinicians, the actual decisions, and there are no other participants involved in the clinical decisions making in both areas. It is a state-based system, and this is the big difference compared to this insurance-based system. Even nowadays, I suppose, even most countries in Europe are based on this insurance-based system, and I realized that this is a very important defining aspect, and also a kind of dividing aspect, because if we work in an insurance system, we have to take into account more players on the playground compared to how the situation is with us. And I would suppose that in this respect, the system in Finland, it's easier to control for the clinicians in that respect. Of course, we can all the time ask if we have enough resources for the healthcare or social care, as in any other context, and the tendencies for decrease the investments of the psychiatric healthcare because of the economical crisis, and so it's always a question of political decision making. But nevertheless, this is the system. Concerning the situation of healthcare, concerning the situation of psychiatric healthcare, it's mainly free for entire population. If only in case you are hospitalized, you need to pay a fee, which is a daily fee, but the fee is not the real fee, but it is always kind of defined by the state what is the hospital fee. But every citizen is a part of a national insurance, and if you are hospitalized, you are described as being on a sick leave, and because of those sick leave, you also have a kind of allowance, daily allowance for the national insurance, and this daily allowance is actually more than to pay the hospital. So that is in that way the insurance system is also a part of the Finnish tradition. But we can say that this is free for the if you are in need for having a consultation in mental health outpatient clinic, that's free. If you are in need of having a consultation inside a psychiatric clinic, that's free. Of course, visiting social care is free, and so on and so on. There are, if speaking of actually, it's a bit different in different Nordic countries, but in Finland there are two kind of disciplines. The other one for the social care and the other one for the healthcare. And if we speak of the healthcare is basically organized in two levels. There is this primary care organized by the municipalities. Small, or regardless of how big city you are, you can have a bigger city in Finland, Helsinki, about 600,000 inhabitants. They have their primary care as well some municipality with 3,000 inhabitants, they have their own primary care system. So that is the basis for the population to be served. And the other level is special healthcare. And the special healthcare system is organized by municipalities coming together and organizing a union for health districts. And all the country is divided into 22 health districts who takes care of all the special healthcare, including psychiatry as one discipline among other disciplines of medicine in this health district. Actually, when we started the development of the practices in early 80s or until the late 80s, it was divided so that there were special districts for the mental health work. But the early 90s they were united, and actually people working in psychiatry mostly think badly about it, because it meant that the position or the profile of psychiatric care was not that, no longer that high as it was by being a kind of organization by its own. But of course the motivation is to have the psychiatry as a part of medicine. But there are all the way around, there are always decisions, political decisions that affect the system of treatment in many places. Most part of psychiatric treatment is organized by these health districts, so it's a part of special health care. And in both the community mental health, outpatient mental health care, and hospitals are always a part of it. But nowadays there is a variation that some cities, some municipalities have taken this community mental health care as their own practice. So there is a bit of variation of that. But all the same ideas are followed in whatever is the situation. Lately, this was quite a peaceful situation until early 90s. 1991, we had an economic catastrophe in Finland. And after that, many things has changed. And one thing that has changed is that there is a tendency of privatizing services. And privatizing services concerns, for instance, since, let's say, perhaps a bit more than 10 years, there is a whole new system of occupational healthcare that has become a very powerful part of the healthcare. And now, of course, occupational healthcare is only for people who are employed, and the rest of the people are not. And for instance, there's a big interest for doctors to move from primary healthcare to work in the occupational healthcare. And occupational healthcare is mostly organized that they are private companies to organize the system, and the services are bought by the enterprises for their workers. And of course, in social care, there is a tendency of privatizing to have this service homes for private homes, supported sheltered living homes, and so on, and in many respects. And perhaps one part of the tendency of privatization is that many of the therapists working in the community mental health now are more and more going into the private practice, either by having a half part of the practice as a private practice or doing that as their main job. Both doctors and psychologists, but also in some amount nurses who can have access to psychotherapy. And actually, last year there was a new law that defines that the national insurance now is, they are actually obliged to pay for psychotherapy if the doctor has defined there is a need of psychotherapy. So that there are also state-supported tendencies in this privatization. So this is a kind of general frame of the Finnish context. Not any full description of the history, but of course we can have some fantasies how this is going on in the future. I wonder if you have some questions.
I have some questions. So how do patients decide which hospital they want to go? And are the quality of the hospital services all the same?
There is a, there is a new law that currently that you can choose your hospital. But actually, because there was such a long tradition that we are organized to have these catchment areas. And if you in every catchment area, the system have entire responsibility for the entire population, and which means that you belong to that area and you use that hospital, that outpatient clinic, and you do not go outside. And I suppose even if there is new law, this is still the case, that you use the hospital in which you are living, and very seldom people go to outside. Of course, it is the doctor who prescribes, decides.
Is the private practice a for-profit, individually owned organization? Yeah. So there is a corporate structure now.
Yes.
That's profit making.
Yes. Yeah.
And who? So you said that physicians prescribe.
Yeah.
But who also does psychotherapy? Is it there are PhD level psychologists? Are they psychiatrists? Are they master's level clinicians? Are they social workers? In the U.S., we have a myriad of people who provide all kinds of mental health services.
In Finland, actually, we have I have to say, we have quite a good system of training of psychotherapists. There is a specific law to define. It's called a law to have a license to use the professional title psychotherapist, and you have to have an access of specific 3 years training. But it's a multi-professional training. If you have a kind of at least college level training, so you can be a doctor, psychologist, social worker, nurse, and some specific other discipline also who have access to this training. And this training can happen in individual, group psychotherapy, family therapy, and of course different forms of individual therapies. And after that you can start your own practice. And this national insurance actually is paying for automatically for physicians, but also for other ones as defined. You can have as it's called professional rehabilitation money for 2 years, for instance, going into the psychotherapy, and after that it's considered, and after that the decisions are made 1 year per se.
So there's sort of a core curriculum that people from different disciplines have to complete.
Yes, yeah. And now there is a new law actually coming into function at the end of this year, that all the training of psychotherapists will now take place in universities. There has been a kind of variation with the private institution taking care of that, but now we want to highlight, emphasize the scientific quality of the and actually that's a big part of my work at the moment, because that's my discipline on the but I can say that that's quite even not optimal, but compared to many other countries, this is a system to guarantee that there is at least some kind of quality insurance of who having the title of psychotherapy, that it should be follow some rules. Some space idea. Perhaps that's it all. Finnish system.
It's pretty clear. I'm sure we have more questions as you talk.
Yeah. This is, of course, a bit of what I was saying, that for me, when I'm coming here in USA, also when I move nowadays quite a lot in Germany, this insurance system is very, it's very different, in which I'm used, and it is an issue that I have to myself use to think that there is always another actor also in the field to take into account. And when I speak of the history and the development, so we have to say that this was some part of it was so easy to put into function that is not so easy in many other disciplines. Okay, then say some words of the history of the Finnish background, the Finnish psychiatry concerning treatment of psycho. I'm not so much speaking of the traditional psychiatry on the whole, but speaking of the tradition of treatment of schizophrenia and psychotic problems. But already now to say that our system is not specialized to take care of psychotic problems, but it's for all kind of mental health problems. And psychotic and schizophrenic problems are the ones that are mostly researched and focused in process because they are the one, perhaps the criteria for the services. People become chronified mostly because of these problems and not so much because of other problems in their life. But it's that's a kind of motivation to use that as an example of describing the system. When we speak of treatment of schizophrenia, we always need to refer to Professor Yrjö Alanen. Yrjö Alanen was a professor in psychiatry in Turku, and a very remarkable person in the Finnish psychiatry. He started his work and career at the 50s, making his first research on schizophrenia families. At that point of time, he was quite much related with Theodor Litzlein and some other Americans who were also working in the same discipline. At the 60s, Yrjö Alanen starting a professor in professor of psychiatry in Turku, had an interest to make it possible to have for the population an access to qualified psychotherapy because of psychotic problems in public sectors and things. And as you remember, this was free for the population. So this was not the kind of specialized service for people who can afford to pay, but this was aimed in Turku to have individual psychotherapy, psychodynamic psychotherapy. Yrjö Alanen has training as a psychoanalyst and psychodynamic ideas. It has a very strong tradition in treatment of psychosis in Finland. And that was the case at the 60s. And the important aspect that those people working in Turku with Yrjö Alanen always remind is that when it was a public sector services, they did not select the clients. All clients need to be taken care of, and if it only was thought to be one part of the treatment, they had access to actually quite qualified psychotherapists at that point of time because they were very much trained to focus on psychotic and schizophrenic problems. But already while doing that work, they realized, and of course because Yrjö Alanen is a researcher in families, he described once that it was an uneasy situation that they focused so much on the individuals, even if he knew from the beginning that psychosis is a problem for the entire family, and you need to have some ways to work with the rest of the family also. And this, yeah, please.
Did they look at the schizophrenic, the families with the schizophrenic in it as a blaming?
No,
because we did that here pretty strongly.
That
identifying commonalities of family members to create the cause.
And speaking of schizophrenic mother and so those kind of ideas. Yrjö Alanen in the very first beginning, he had a much more open kind of interest of what is the role of schizophrenia in the family, what is the place of a family member who have a diagnosis of schizophrenia, how are these families living, so that he didn't have so much treatment-oriented idea in the beginning of the idea. But the response that they got when they announced their interest that we need to have place for the families to be involved in the treatment, that was starting to look at the so-called systemic family therapies that started to emerge at the 70s. And that was the first thing they started to do working with family in Turku. Having a team, the systemic family therapy idea, especially when we followed the idea that became so popular, was the Milan systemic family therapy. But that was in the end, towards the end of 70s. But the idea, very important idea for the future development is that family therapy introduces a way how to work as teams. Because that's the basic idea that when you work with family, it's always was a kind of presupposition in the beginning that you work as team with 2 persons or even with 3 persons and then this Milan systemic idea became very popular. There were one person having the interview with the family, and then the rest of the team were sitting behind a one-way screen and looking at the meetings, and then they could have some break in between in which the therapist and the team met, and then in this meeting they formulated a kind of positive connotation for the family of the issues that has been discussed. So that was the first, or one of the first ways to doing with families. Actually, not the first, because there were also one German tradition organized by a psychologist, Helm Stierlin, who had a very strong kind of generation perspective of how these families have a different kind of way to legitimize the second generation of the issues concerning the family life. But then quite soon afterwards this systemic family therapy became a part of it. But still there was a problem, and the problem or a dilemma was that it's a kind of method focused idea. You have individual psychotherapy, you have a systemic family therapy, how to combine. And in the end of the 70s, they started to come together with an idea, as they started to name as need-adapted idea of the treatment of schizophrenia. But that's something I will come later on and speak more precise about it. Nowadays, there's quite interesting kind of analysis of what they from the very beginning they have made follow-ups of their clients, and now they have made a conclusion that interesting conclusion that there are different steps they develop in which they increase always a new method of treatment. And the conclusion at the moment is that every time when you add new element of treatment in the ongoing system, that increases the good outcome of the population. And that's quite important idea of the whole, not to think of single methods that we are so occupied nowadays, but things that we need all the time to look new options in addition to that we already have, not instead of that we already. And of course we nowadays know quite a lot of that, for instance in psychotherapy research, in which is nowadays has become more and more apparent that change for the better in clients and family is not because you apply this and that specific method, but it's more because of those common factors. Common factor mostly focusing which kind of relation between the therapist and the clients is put in front, and this is the basis for good outcome and good change, regardless what is the name of psychotherapy. So already 20 years ago in this need-adapted idea, they were very much on the same lines to focusing on. Not to choose, you either use this method or that method, but try to find ways how to integrate the different methods into a joint process. As a one kind of early notions that became quite many of these aspects became quite important questions to or a kind of starting point for the need of developing in a systematic way the treatment of schizophrenia. The first notion is that in the traditional system in which those people in Turku and many of us were living 70s and 80s, and unfortunately also nowadays, is that clients become not heard, neither the patient nor the family members. And of course this is a very big issue, because all our system, our services are based on the idea that we as professionals define how clients should search for help. And clients, in a way, they need to have a training. How can I have an access to the right treatment? And most often what happens, for instance, in our Nordic system is that because the services are specialized, specialization as such can be good, but it's also bad because it's fragmented. If you have an alcohol drinking problem, you go to that clinic. If you have a mental health problem, you go to that clinic. Even if nowadays, if you have depression, you don't go there. If you have a psychosis, you need to go there, and so on and so on. So most often clients have an answer no, this belongs not to us. You have to make a contact to some other places. So our systems are organized in a way that clients do not become heard. That's actually the basic rule of the services. We put the frames and we generate the practices. I've been doing quite a lot of work with in many countries actually with both consumers of the services and family members of the organization of the services. And what we face is so many times with the family members a kind of this loading of the big frustration and bitterness they have towards the system because they have a feeling that they have not taken into account in the system. And this is an important issue, especially in dealing with the most severe mental health problems, because this means that the families, when they are not, they are badly handled in the systems, they are in a position in which they need all the time defend themselves to the system, and of course this is not the optimal way to have the resources to help the one who is in the crisis, and of course to have help support to themselves also. This is when I think of this open dialogue system that we speak tomorrow in a more precise, the idea is the opposite. We start to follow the stories of the clients, we start to follow the stories of the families, and our stories as always secondary. But still, for instance, I've made some research in which I made a comparison between people who came into treatment in a psychotic crisis, and now we knew after 2 years what is the outcome. And we made a comparison of the good outcome and poor outcome cases. And what happened was that making the comparison, we could see already in the very first dialogues difference between these two cases. And it happened that if it was a very difficult situation in the most critical points in the dialogues, what happens was that again the therapist took the lead, and they didn't tolerate the uncertainty that they would follow the voice of the clients and the family. So in some way, this is a big issue that can also in the new system be a part of our practice in an unfortunate sense. The second big problem is the overemphasis in inpatient treatment concerning psychotic problems. There was a long time there was a kind of self-evident case that if someone is making a contact because of psychosis, you are hospitalized for the period of time you are psychotic and then discharged from the hospital after that period of time. And for especially a Swedish psychoanalyst Johan Kulberg, who has been doing a lot of work in individual psychotherapy, and nowadays called himself as a leader at Rose. And Johan has made a lot of analysis and actually also research studies, making interviews with the clients. How do they feel? How do they experience the first hospitalization? And in actually, first hospitalization can be a crisis that makes the problems more serious than it used to be. Johan gave description that in the wards for psychotic patients, the patients become disposed to the psychotic behavior of the other person. If you are used to that, if you already have a history of hospitalization, that's not a big deal, because you know how is the life. But if you are for the first time, because of you already yourself in a very terrified situation because of the psychotic problem, but what you meet is a totally confusion. You meet with people, as Johan described, who can be naked or half naked and come 5 centimeters from the face and speak something I don't understand. And when you go to the smoking room to have a cigarette, someone's come and take a cigarette from the room and so on and so on. So that most often happens that people become more psychotic during the very first days. And those are very harmful because they can open up processes in which you have much more difficulties to survive and recover of the situation. So we need to have some other alternatives for hospital, some other ways of dealing with the crisis than focusing on the hospital. Of course, there are always situations in which hospital is needed, but not in a kind of longer term stay, but more or less taking care of the most critical situation for some days and perhaps to organize the rest part of the treatment. For instance, Johan Kuhlberg organized a unit in Stockholm in which this unit took care both of the inpatient stay and the crisis intervention services. They had very good results of that. The third question is that there is always an emphasis in medication, especially on antipsychotic medication in many respects, so that there is an automacy almost that when you have psychotic problems, you are medicated. And we got a project at the 90s, followed first episode of psychotic patients in this open dialogue treatment for 5 years. And because of having a task as a part of the Finnish national research to find a way what is the place of medication, in our unit the medication was postponed and not started in the beginning, but we wanted to see how the powerful psychosocial intervention is affecting. And actually it happens that only 1/3 of the psychotic patients were put on a medication and 2/3 did not use medication. And even in medication, half of them was discontinued quite rapidly. And then I realized that our outcomes were very good, and they were very contradictory with the recommendation that say that with psychotic crisis you need to be started the medication from the very beginning. And then I started to look after research. What is the evidence behind this conclusion that every psychotic patient should be medicated? And I was very surprised because I didn't find any. I did not find any longer-term follow-up with which compared psychotic patients who are on medications or without medication. Most of the placebo trials, they follow the patient 6 to 8 weeks and make a comparison between what is the difference in the group approximates, and the conclusions are made on those. But actually this group means don't tell anything of the specific, because they don't say anything of the treatment of single clients. There can be statistical difference between group means if perhaps only 25 to 30% of the population goes across the variation of the comparison. And then, because there is a statistical difference, we easily say that this is the rule. Because of this 20% of clients, we actually put that as a rule for the entire population. And actually, I came into a conclusion that this is a non-research issue on the whole. There is it's a British psychotherapist, Max Birchwood, who said that actually there are 3 longer-term follow-ups, and the most important one is the one by Lucy Johnston and others that made in London at the 80s, followed 2 years' time. But even their results were very confusing, because actually what they found out was that those patients who were not on medication, they managed much better concerning employment status. And when the number of relapses was persistent, there was a slight difference for the advantage for the medicated patients. But even those who were medicated, 40% got a relapse, 42%. So why do they need medication if they don't have use of the medication? And 60%, 58 got relapse of those who were not on medication. you have some advantage of the medication, but again, most part of those people would not have use of medication. So the much more important question in medication is to try to find the patients who can take use of the medication instead of thinking that everyone should be automatically. As I think nowadays there are three critical questions in that. Who can manage without it over the psychotic crisis? Second question is that who can take use of the medication, or this medication can be usable for some of the patients. And perhaps the most critical question is to ask that for whom the medication can be harmful in many respects. And this is a challenge. How can we organize our system that makes possible to take into account all this issue instead of automating in the medication? Because medication can also be harmful. And of course nowadays there is even some studies that shows that it can be, if you have all too overemphasize in medication, it can increase mortality, or it can affect some changes in brain, that unexpected changes in brain function. The fourth point is perhaps even most interesting, at least to me, to think, because there seems to be a kind of overemphasis in finding out the psychopathological aspects of psychosis. It's almost only seen a kind of, when it's defined to be a part of an illness, it's seen as a symptom of some illness with qualities that has to be taken away. If you think that this is a symptom of quality, that leads into a situation in which you aim your treatment on those symptoms, having the symptoms away as soon as possible, or as it say, stabilizing the condition, for instance, before we can do something else. And this you don't take into account all the aspects that are related with the psychotic experience. The first one is that psychotic experiences, hallucination as a core of psychosis, they are much more popular than we think. That they are much more, the incidence of those is much higher than we think. There are studies that have shown that half of people could have experiences that can be defined as hallucination. There are studies that show that perhaps 4% or a bit more have longer term hallucination in their life, and only 1/3 of those ever come into a treatment. So actually most part of psychotic problems are lived through and experienced by people who never been in any treatment. So, and of course this is a conclusion to be made that psychotic symptom as such is not a kind of criteria for treatment, either to start a treatment or to go on to the treatment, but there are other aspects who are related. There is a Dutch research by Adrian van Honing and others who made already 10 years ago a kind of comparison. If there is a difference between auditory hallucination of those who were in treatment and those who never had been in treatment. And they didn't find any difference. They could have been standing as long in both cases. They could have some kind of traumatic experiences behind them. And so on. So again, this is a very interesting question to think that what are the aspects of having psychotic ideas and how the treatment system should deal with this. And if we have this overemphasis of psychopathology, we do not see the potential resources. And the potential resources comes out of the noticing that we have made, for instance, in the research in which we did not have medication, we realized that people in the psychotic experience speak of real incidents in their lives. So that psychotic speech, psychotic experience is not at all be only a kind of non-meaningless produce of something, but it is related of life experience. Many times those life experiences are quite heavy, and they have never before been speaking before. And now the psychotic way, hallucination can be the first time ever to have a possibility to have words for some experiences that were not possible to speak before. And of course, if this is the case, we need to have a kind of new way of dealing, not to think that this is something we have to take away, or this is something we have to define as a part of your symptom, as is many times done in some schools of psychoeducation. In psychoeducation, because there are many schools that work in a very psychological way, but in some ways it's very strict idea. If someone is speaking of hallucination, you are said that this is a part of your illness and this is the reality. It's called reality orientation of this. And my proposal, and of course not only my proposal, but also in the tradition that we have been done, is to have a curiosity of what is it related to that someone speak of psycho. Concretely, for instance, in every sessions in which someone starts to speak of the hallucination, I'm used to stop everything else and have a, wait a moment, can you help me understand a bit more? You said that you have a control of neighbors' thought. How can you do it? How does it happen? And in that way, we could have a much more place for speak of what is it related to. This and that kind of experience has emerged. And while doing that, there is so much more place to have different kind of voices to become heard. Now I don't refer to any hallucinatory voices, but something. Okay, these were a kind of experiences of some of the early conclusions that were made by working with psychotic problems, and perhaps especially those people who have a kind of psychotherapeutic orientation in psychosis, they are much more motivated to look at in a broad perspective psychological meaning, even with hallucination. And this is taking place in every discipline of psychotherapy. Nowadays we know that in cognitive behavioral therapy there are very interesting ways to develop our practices, how to deal with how to speak with the hallucinations and so on. But these dilemmas were already there in early 80s. And in Finland, of course, many other conclusions. One of the conclusions was that in Finland there was a very strong emphasis of hospitalization, so that there were a highest number of hospitalized patients in the world actually in the early 80s, and that was one part of the background of having a national schizophrenia project at starting probably year 83 until 89. It may be that I remember the years, but it happens at the 80s. And the schizophrenia project included around about 50% of the population, services of the population, and was focusing on two aspects: the acute treatment and longer term treatment. I will not here speak of the recommendation of the longer term treatment. But as the work of this schizophrenia project, there became a kind of, as a conclusion, recommendations for the new treatment for schizophrenia patients and psychotic problems. And perhaps the basic general, without not going into the details concerning this basic idea concerning how to organize the treatment and what is the basic problem, is instead of having the hospitalization, to have a system that makes possible more and more including the family in an evaluation phase of the treatment. that was the main recommendation of the system. It's of the national schizophrenia project that said that's the first thing that professional need to do is to organize immediately family-based evaluation of the problem, so that family is there together with the professional to define what are the actions to be taken. And to make that possible, the schizophrenia project proposed that in every district there should be a kind of network, as it's called, psychosis teams that focus on taking care as early as possible psychotic crisis. And actually, since late 80s, there is in Finland a network, almost every district, and it is a kind of manner to organize this psychosis team, or nowadays they are more named as acute team. In the actually it became also a problem to name those as a psychosis team, because they were taught only to work with psychotic problems. But actually from the very beginning it was noticed that there is actually no sense to have a diagnosis-based system, but it's much more accurate to work in a team to work in a team in many different kinds of crises. And as a basic quality of this work, to have the idea that we integrate the different therapeutic and other methods of treatment into a joint process. Tornio was not part of this schizophrenia project officially, but at the time when I was working here, immediately we took these ideas as a part of our practices and welcomed very much the recommendations, because we were on the same track, and those reports gave us guidelines how to organize, what are the critical elements of the new system, and actually many nowadays say that this is put into practice mostly in this.
I have a question about the psychosis teams.
Yeah.
Are they in every one state out of the 22 districts, right?
Yeah.
Or in the 6 districts?
In the 22 districts.
Okay,
Yeah.
in the 22. Okay.
Yeah, and actually not only one, because in one district there can be many cities, and in every city there were those kind of.
And these districts are natural districts or healthcare districts?
Healthcare districts.
Healthcare district.
Yeah.
Okay. Thank you. I'm just trying to understand in terms of the, sometimes in a country you have, in China provinces, here in states, and then in each state we have something.
Yeah.
I wonder whether this district is something like states in the United States.
It's not a state, but it's a very relevant question, because partly the boundaries of this health district were the same as this. We don't have states. We have let's say we have province. This province is a state organization from up to down.
Right.
They are partly the same, but they are not the same, because this province is a state organization, and health district is communal organization. It comes out of the municipalities. So they can be part of the same. They can overlap, but they have their own administration and so on and so on. It is perhaps it's the very same as you refer in your country.
Mm-hmm.
I know, for instance, that in Norway, I'm very much working in Norway, this is the same. This is Norway, they're called fylke. That's both the state and the health district, so that they take care of the system. As it's always also in Denmark, and probably also in Sweden, but not in Finland. So that there are this kind of variation of the system.
So each province might have a few districts?
Yeah.
Okay.
For instance, Lapland in Finland is one province, but there are two districts, two health districts.
Okay, yeah, that makes sense.
Yeah.
Thank you.
And some health districts goes over the province boundaries also, so that it's sometimes it's complicated.
How many people would be on, there's 3 or so people on a team, but how many people in a district team? Do you have 30 or 40 or?
No, they were quite small teams, and actually in the beginning most of the teams were organized by the job basis. So that one part of your job is to be in this psychosis team, even if you work as a psychologist in the mental health community care at the same time. So that it could be that those teams were formed, for instance, some 6 to 8 therapists, and they had a responsibility for perhaps some population between 50 to 70,000 inhabitants. Actually, there was also one part of the National Schizophrenia Project was to say that between 60 to 100,000 inhabitants is quite optimal inhabitant rate for a psychiatric unit to be organized, and it was thought that this kind of unit have their psychosis teams also to be responsible. But that was problematic because not all the teams were enough occupied, so that they could be overloaded in 2 weeks. They started their work, and even if they had a kind of ideology in their treatment that they focused more a kind of working as a team, having the entire responsibility, they were overloaded. And in those regions in which they thought that psychosis team becomes a part of the system, and from the very beginning they invite those other professionals of being part of the system, they managed better because there were much more flexibility in that. And there is always some interesting detail here, because when this psychosis team was quite big operation in Finland, when they were organized, they started to work in such a different way compared to the traditional outpatient mental health services. And what happened, they easily were in a conflict with the traditional, because those working in traditional care said that you only are free all the days, and then we come to your meetings and so you don't take care of this and that you should take care of. So that immediately there was always a kind of danger of where these two cultures met, that it was not taking place in a such constructive way. But if this psychosis team had an idea that they always work together with the people of mental health team, for instance, they manage better instead of thinking that they are the unit. And therapists themselves also become very enthusiastic of their work, which is good issue, but it can also arouse a bit irritation by some others. So that this system of psychosis team really made a big difference in the culture of psychiatric system of the whole tradition. And that's what I call, but also in the other Nordic countries where I see that this seems to be repeated many times even nowadays if this idea is put into practice in different provinces. The most systematic kind of conclusion of this Finnish national schizophrenia project was the as we call need adapted approach. And now I'm coming back to the work of Yrjö Alanen and his team, who were the main part of developing these new practices. And around the same time, actually, those people were mostly those who had a responsibility in this part of the National Schizophrenia Project. They made a kind of conclusion of 4 or actually 5 principles of how the treatment should be organized. And the first idea is, as it's written here, that therapeutic activities are planned and carried out flexibly and individually in each case, so that they meet the real changing needs of patients, including the patient's family. So actually, this says many things. Being flexible and individual means that we do not follow one program of treatment that is based on a diagnosis. So this is quite important. This is not an idea that we need to have diagnosis, and after the diagnosis we know what is the treatment and what is the program that is needed. But actually this says very much the opposite, that in any case, regardless of the diagnosis, you have to come together and find in a flexible way the individual needs to put the treatment, the therapy in practice, and of course applying, adopting those methods of treatment that are suitable here. And the other question is needs. What are the needs? And what this definition says also that the needs are not at all a kind of stable quality of the life, but they are changing needs. In a crisis during the very first days, for a family, the need is very different compared to how the need is after 3 weeks of treatment. And of course, the team working with the family have to be very sensitive to realize that now this is a different situation, and perhaps there is a need for different kind of ideas on that. And the third point here is that it concerns the needs of the patients, but it concerns also the needs of the family members. Second part is that the treatment is dominated by a psychotherapeutic attitude. Again, actually quite a big change of the traditional way of doing, because what is said here is that what is the guideline for us as a therapist is that I have a psychotherapeutic attitude. How does my reasoning in this issue, how does my involvement in coming to make a decision of the treatment, what kind of psychotherapeutic effect it has? And it's no longer a question what kind of actions we need to take from our point of view to have a control of this situation. So this psychotherapeutic attitude is one way to describe very important aspect. Psychotherapeutic attitude in my mind very much resonate with psychodynamic tradition that these people in Turku had in mind. The third point that the various therapeutic activities are designed to supplement each other rather than to constitute an either-or approach. So it's at that point of time we had in Finland quite a lot of debate and discussions. Should the different methods to be used as in line? First we use this method, and then we use this method, and after that we use the third method. But what was said here is that we can use different methods at the same time. We do not have any timing, because at the same time one can be in individual contact, individual psychotherapy, and there can be family meetings, or there can be family meetings at the same time the patient is in need for occupational therapeutic support, and so on. And also there can be ongoing psychotherapeutic talks while the patient is in the hospital. So this is of course the question of integration on the whole, integration of the different ways of thinking. And not to think that they are against each other, but actually they can support each other. This is not easy because for instance, I have in my mind quite dramatic experiences of a situation in which, for instance, one psychoanalyst who was working, actually he did very good work with severely psychotic young boy who came into our treatment. After he had almost killed his father. He was 11 years of age, and so autistic almost, and psychotic. And this psychoanalyst had a 12 years very active relation with him. That was good, but he denied to become a part of our meetings with the families, and that was a very unfortunate situation in many respects. Family became very angry, and family became very angry to us, and it meant that the family almost broke the connection, to be in connection with us, because they did not at all understand why does this doctor not come to discuss with us of this situation. So, for instance, for me, this means that I very much encourage people, individual psychotherapists, for instance, coming into the meeting if there is a need for most often you can protect your transferous relation, as someone has called that in suppositions that his family members don't threaten those families. The fourth point is the treatment is set up with the aim of achieving a continuous process and maintaining this process. This is a question of process quality of the treatment, and this what is focused on is the focus on the idea that we think that we are now in a process and we are not in a need that we have to always respond in any occasion. We don't have to be reacting all the time, for instance, if someone has more anxiety than he used to have. But we can understand this belongs to this process and we can tolerate this situation and see how it's going on without reacting in the need, for instance, that now this young man has to be hospitalized because he's agitated or he has more anxiety. If we think that's a part of a process, we have more tolerance and strength to handle this kind of situation. The fifth, this was something that came later on, this fifth point, that actually that's something I already have spoken. That all this is made possible by organizing acute or psychosis team to make the crisis intervention possible, a kind of opening is interesting. In one way or another, all these ideas are included in the open dialogue principles or principle that I will speak later on in more precise. But it's even if in not these terms, but for us this was very much of the very much a kind of support to go the way. One support to make an opening in the new way. From the very beginning, when we started to develop open dialogue practices, we realized that this is very different. And we were challenged by many notions that you are not following this and that. But we felt very safe because we could all the time refer to this national recommendation. Look at here, what is said here, and we could say that actually what we were putting into practice followed the guidelines that were nationwide accepted as a basic idea. I wonder if you have some comments or questions concerning that. Again, what this means in working in psychotic problems, psychotic situations has been main interest for us in many ways. And from the very beginning, when it was noted that psychotic patients have many qualities and much more resources than it was thought before. And of course the background now is to think that before this new guidelines in Finland, psychotic patients were put in the hospital quite automatically, and there were not so much place to think that psychotic experience could include some resourceful, but you need to be in hospital as long time as needed. And many times it was very catastrophic situation because we know that, for instance, the hospitalization can ruin the social network and isolate the patient and as such generate a process towards a bad outcome. And it's not the question of the problem, it's not the question of what is the psychosis, but it's the question of what is our response. And for that reason, during the years it has been very important for me to give a thought, how do we think of psychotic problems? And how do I see now, as many others also have said, that actually it's a bit misleading to speak of psychosis as a kind of entity, because there seems not to be any that kind of entity. Psychosis as such, as a category don't exist, does not exist. Psychotic behavior can be related in many type of experiences, can be related to many type of brain function, it can be related with many kind of other conditions, and it's only by name that we can put those together. And many times when we, for instance, read psychiatric textbooks and read descriptions of psychotic problems, we easily see a kind of description of some specific quality of behavior that psychotic patients have, for instance, in their reasoning of the reality and so on. But actually when we read those further, most often what is used behind of those ideas is people who have been quite long time psychotic already. And my question is that in those cases, is it a case of the illness that has caused this kind of reasoning? Or is it the case that actually what has happened is that those people in a stressful situation has a kind of odd experience of life? Odd experience can be that all of a sudden I can start to hear some voice or sense something that is not there with smell or whatsoever. And when I have this kind of quite dreadful situation, it can be the case that I start to make a strategy for myself. How do I survive this situation? One patient said that, for instance, when he had a voices speaking to his ear, and he was facing a chair, and when he was crawling on the right hand side, the hallucination became stronger. But when, by chance, it happened that he was choosing the left hand side, which voices were not so. And then what happens? All the time when he's facing a chair, he's doing like this and choosing the right hand side. And then we meet with this kind of odd behaviors with those patients, and we easily think this is a sign of psychosis, and in my mind this is a more a kind of psychological strategy. How do I deal with those experiences? And of course for our family members, this can be the challenge that family members, if they are not met early enough, they start to generate a strategy. How do we deal with? Now we know that our son is in hospital, it's a heavy thing to us, but now he's in good hands and we can relax. And this is a strategy for dealing that now we have one family member who is sick, but we can deal with this, and they have this identity of being a family in which one person is psycho. And in my mind, if we think of long-standing psychotic problems, instead of thinking that it's the illness that makes these people in such bad situation, it's much more a question of asking that perhaps it's a question of poor treatment instead of illness causing it. And poor treatment in two respects. The first one is that treatment starts all too late. All too late means that treatment starts so late that people have had time to create strategy for their experiences of reality. And treatment systems should be organized in a way that makes possible to be there before they have had time to have a strategy. How kind of strategy do I do to my threatening experiences? And the second big background for the poor treatment can be that there is a kind of non-adequate understanding of the problem that easily leads to wrong treatment, wrong response in the treatment. I mean now isolating the young man from the family, from the peers, from the social situation, and put him into the hospital without connection. And in the hospital we easily have ideas like that now he has to calm down and we don't have any meeting before he has calmed down and he's capable of participating in the meeting. And all these kind of things can be actually quite harmful for the connection, for the social connections of this young man. And of course, a second big question can be that easily, because of psychotic experiences, people are medicated, quite heavy medication that takes away of some part of their psychological resources because of the sedative effect of the And now we are in the facing the end of the first lecture that I thought to give concerning what are the origins and background of this. So the origins of coming into the open dialogue idea is that we started to work in a small province in Finnish Western Lapland, having this as a background the Finnish system of treatment, which gives us some basic prerequisites to work and reorganize the system. Actually, we always said that we could do whatever we wanted to do in those resources we had. There was no one to say that this is not possible for you. And of course, this is a big opportunity on the whole. And we had this interest of treatment of schizophrenia. For instance, psychotherapeutic attitude was very much present in all of our work. I had an interest doing individual psychotherapy with the clients. We had an interest of doing family therapy with the clients. And we had a support of the Finnish need-adapted approach. Actually, one person of the team of Yrjö Alanin, Professor Jukka Aaltonen, was our consult from the very beginning and still is. And nowadays, Jukka Aaltonen is my main co-worker in the research that we have been doing. So we were very nearly connected with that, which gave us support and encouraged to go on. We had a tradition of having both individual psychotherapy for quite several psychotic patients and have the tradition of systemic family therapy. And we were actually quite uneasy with the systemic family therapy because very few families had access to that kind of treatment. And the big solution for us came out of the notion of this Yrjö Alanin's team in Turku by a need-adapted approach in which they have generated a new forum for this treatment. And the new forum was of these therapy meetings that we learned about 1984. It's an open meeting into which the clients, the patient is always present from the beginning, and it's a meeting into which the families are always invited, instead of thinking that this is family therapy, that there is some indication because of the interactional problems within the family, and that's the reason we invite the family. But now it was the kind of automatic. Always when someone is hospitalized, we invite the family to be a part of these meetings. And this meant a big change in the family situation, because family was no longer a kind of target of our interventions, but family became a resource in finding ways to go. And of course for family this means also now they really had a possibility to become heard. As I said before, that was a big problem in the traditional psychiatry because it's organized on our premises, and now this open meeting is a forum in which everyone have access to become heard, have possibility to become heard. And when they become heard, they can have more and more use of their own resources, and of course they also have support and safety for themselves to tolerate the situation in which something has went wrong in their life. What happened when we came into this new way of working in 1984? Immediately we got very good outcomes in a very difficult situation, unexpectedly good outcomes. But at the same time, we met quite many times confusing experiences. And those confusion came out of the fact that we didn't realize at that time that we actually had taken a step into a new frame from the old frame of treatment. And the new frame was a kind of open forum in which family came as a part of the process in a very active way. They wanted to have their voice and they affected the treatment, and we no longer had the possibility to control the treatment by our treatment plans, by our interventions. And the only way for us to go on was to adapt our behavior to the specific needs of the family. And that was a big change. That was a big confusion that was aroused in many cases of treatment. Actually, many times we realized that we are in a dead end. Whatever we try, whatever plan we try to follow, nothing could seem to come out of it. And all of a sudden, if we changed the system, started to change. Those kind of experiences were a background to us to decide that we need to have do two things. First, the education that we as professionals have do not at all give prerequisites to work in this new discipline, in this new way. So we need to have a new training, and that meant that we started to have this training, actually psychotherapy training, in the way that we had some comments in the opening of my presentation. And since '86 and since '89 officially in this health district in Western Lapland, psychotherapy training has been a part of the program, so that every staff member who work there have access of 3 years training in this system. And actually now, after 20 years or a bit more than 20 years this has been going on, the density of psychotherapists is highest in this small province in Lapland concerning the entire density of psychotherapy working in the public sector. So we can say, in other words, that this is the highest educational level of the staff compared to any other district in And the second big conclusion for us was that we need to understand more both of the processes, what happens in the treatment, but also of the outcome. Is this good or is this bad? And that was the origin of ongoing research process. And nowadays I try to formulate in the way that when we come into a new system organizing our practice, what we need to do at the same time is to have a possibility to make an evaluation of our own practice. And that's the place that we cannot do new practice if we don't have research about our practice. And this research is now a bit different compared to traditional research, in which the researchers come from outside and we make evaluation of one method and its function. And now we want to understand the entire system, because this is valid for the natural setting. So in the natural setting, most often in several crises, we use different methods, integrate different methods, and actually very seldom use only one method. But most of these clinical trials look for one method action, and this is not valid for the everyday practice. And perhaps we can say that this is the mostly, because these studies are going on all the time, so this is mostly studied, scientifically studied system of psychiatry in Finland. And actually I don't know in the world many other systems that has been so much studied as this. So this is very, very basic ideas on the whole. So this last slide is that I try to, only for the purposes today, to put some time frames for this development. So first, when we started our practice, we did not name that as open dialogue in the beginning. There was this phase, perhaps 3 or 4 years, to have different methods of therapy. Some part of that was very well functioning. Some part of it caused uneasiness to us because we did not reach all families, for instance, as we wanted. And the big change happens in 1984, to come into this open therapy meetings with, as I said, there were good outcomes and confusing outcomes. One of the outcomes was that when we started to organize these open meetings within hospital, we realized that we really are there too late. Many times to come into the hospital, even in the hospital settings, you have to wait 1 week before you have time for the first family meeting. And that was the basis of reorganizing the system on the whole, and since 1980 or 89, the whole district was organized with mobile crisis intervention teams. We had our first research, 87, to look what happens in the admission when we have the first meeting when patients are hospitalized. In that research, we realized that 40% of the referrals would be dissolved in the first meeting if it was organized. And now we're facing half of the crisis, half of the severe mental health crisis to be possible to deal while doing home visits and instead of coming into the hospital. And this system was then organized since 87 or 90 in a systematic way. And in 94 to 96 we had a large research project with Luca in which we analyzed what is the difference in the new system, crisis intervention-oriented system compared to the older one, hospital-oriented system. And these guidelines for open dialogue, as actually that was the first time we named the system as open dialogue. Okay, but that's a story for another time.
In China, families are very, very much involved in everything. It doesn't matter whether it's a psychiatric problem or it's, you'll get a cold.
Yeah.
So you go to the doctors, then your spouse or your parents will come with you.
Yeah.
And then they sit with you throughout the interview with the doctor, and then they get involved in decision making.
Yeah.
Do you see that is happening to Finland in terms of general medical practice or just in the psychiatric services these days?
Of course, mostly like this in psychiatric services, but I think you make a very good point because I think that I am also thinking about it. There seems to be culture that you can call this is a family culture, and you describe that China is a family oriented. Finland is a very family oriented culture. In Europe, for instance, some Spain or Italy are very family oriented culture. But I cannot say that's the same from France, for instance, because they have very strong focus on individually based treatment methods, for instance. And it's very interesting to look at the cultural differences. But I suppose that in some places it's very easy to focus on those family strengths, and some places not. I have some experiences, for instance, here in the United States. I had a lecture in New York, University of New York, a year ago, and there was a lot of survivors in the audience, and they did not. Some of them, of course, only 2 of them had a speech that they were very strongly against what I spoke, especially because of my focus on family. And their experience for family was totally negative. Nothing good for the family. My only way to survive is to deal with myself. And of course, they could have been experienced that kind of things from the family side. That's reasonable. I started to think that perhaps that sounds not so family-oriented.
Bill, do you see that can be implemented here, the family approach? I'm just curious, what we take into the cultural differences into consideration?
Actually, I think one of the things we were talking about this earlier this morning, but in our child delivery systems, the involvement of the family has gone from being tangential to being sort of center focus. And sort of the involvement of the parents is really sought after and listened to, which is a big change in our larger delivery system, and that's happening in our inpatient and residential child programs. 20 years ago, you didn't want to see the parents until like month 3 or something along those lines, because you wanted to help the child and you assumed the parent had something to do with the child being there, and now it's completely turned around. And sort of the sooner you're working with the whole family system, the better. And that's, we have 3 major projects that are going on in Central Mass with about 500 families that really focus on the family involvement right from the beginning. Doesn't necessarily tie into all of healthcare, but the development of the medical home will be that, sort of with the child and the transition age child, which I think we're all trying to figure out, at what point is family traditionally important, and it might be more cultural at that point than developmental. In some cultures, to have the family continue to be strong bonding through to age 26 is normal, and other cultures it might not. I don't know.
That sounds very, very good point, because what you are saying at the same time is that your practice is actually family construction, so that when the family have a role in the system, that being a part of the system can be very constructive experience for the family, and it increases their connectedness.
Yes.
So that it's not only that they are this kind of families before and after, but after this experience they have more and more related with each other. And that's something we have also experienced. Some family members say that we learned how to be the family in this process.
I mean, it was delightful over the years to watch at the first time we brought people to the table, family and staff, and not just our staff, but other agencies who were in charge, if you will, or at least in charge of the money, if not in charge of something else. And everybody was struggling over control because nobody wanted to give it to the parent. And once everybody figured out, well, if you do that, it actually works better. We can't give away our money, but we can give away this process. And it really is effective. But it took a long time to get people who had spent their whole careers being in charge to say, okay, we can have it, it wasn't an open dialogue, but we can at least have some conversation.
Right. I wonder whether that has anything to do with the generation differences, because the millennium generation, their parents are more involved in general, not only in the medical Medicare. I mean, just in general, in their life, in the school to choose, sending them to different practices. The parents are just more involved. So
and then the kids go home.
Exactly. So I don't know whether that the cultural difference plus the generation differences are playing a role together.
One question I just wanted to ask that was coming up. So much of our point of emergent service and hospitalization, and maybe not just for this population we're speaking of, but for all, centers around sort of an increasing amount of violence, either to self or to others. And our rates of assault on staff is pretty high on our inpatient units. Community situations, people being very concerned when they begin to deal with somebody who has a defined psychotic process and has access to guns and is in school that hasn't been going. There's a real intensity of trying to make sure the community's safe, and then also our staff are safe. And sometimes, medication is the answer in some areas, sometimes it's more aggressive. Do you have situations that could help us or help me understand how you might approach a situation like that with this model? Where there is a high risk, a high danger, high risk.
At least what we have noticed is that, for instance, one of the outcomes that has come in is that the need for compulsory actions in treatment has declined. It can decline already in the first meeting when the families come together, supported by us, even if there could have been some dreadful situation before that. And those kind of violent occasions, both in home settings when people do home visits and in hospital settings, they are quite few. But of course they can be quite dramatic. But whatever is the case, the main idea is to come together and start to discuss and to discuss of the dreadfulness, for instance. I used to work with older Norwegian psychiatrist who he initiated a very interesting unit in Norway, a kind of residential house, and they had a principle what they called ask the patient. It was a house that didn't have any program. Every time, every morning, the program was planned with the family, and they dealt with the most serious cases. Many of them had a violent history. And what they actually taught to us was that when they faced with the one who is threatening, what they asked him, should I be afraid of you? powerful intervention when I, for instance, myself started to ask, what do we? No at all. So that this kind of question can be a kind of opening to the one who acts in a very dreadful way to realize that I'm doing now something that I not control. So that in one way or in other, make that also a kind of open discussion seems to be for that. But of course we need to have control, we need to respect, we need to in some places invite the police and so on in some most extreme situation. But if this happens in an open forum, they may become possible to discuss afterwards all this. And afterwards, of course, we could at least hope that there's more possibilities to have a discussion how do we master this kind of situation in future. So, of course, you are referring to a very challenging situation. Yeah.
I think we're running out of tape, but we can still continue the discussion because they won't be on tape. So we can say anything you want.
Yeah, now we can speak freely.
Yeah, finally.
But I wonder if you have some more comments or questions or what is being.
I'm curious, when you first started the open dialogue, it wasn't called open dialogue.
Yeah.
How was the reactions from different parties involved? You know, the family, staff, and even the government.
Family response has always been positive, mainly. No problem on that side. The patient's response has been mainly positive. No problems on that side. The most problem has been us. The biggest resistance seems always be on our side. Can we really do that? Can we really go? We can't do that. Who is taking the responsibility and so on and so on. So those are the questions when new steps are taken. And in the systems, what surprised me in the beginning was that I had when I was starting this, I was quite young man. And we
You're still young.
Yeah, thank you. And I have a lot, as many of us, has a very how would I put it, democratic ideas. I was waiting for that those people lowest in the hierarchy, they would be most happy to have an access of open meeting, but that was not the case. Those who were lowest in the hierarchy, they were most against of this system. I'm not trained to be a psychotherapist. I'm trained to be a guide in the world. I'm not there.